Okay, this is going to be back to back. I went ahead and I had originally done it as a whole, chapter 40 and 41, but it seems much better when I'm doing the videos to do these very short clips. So I went ahead and split it back out, and chapter 40 is on medications, drugs to use for the upper respiratory system. So what is the upper respiratory system? I put the picture there to help you. It's your nose, nasal cavity, pharynx, the paranasal sinuses. It's very, very vascular. And what is the purpose of it? The purpose of it is it has little cilia hairs to trap particles, warm and humidify the air. Use those trap the particles to clean the air coming in before it enters into the lungs. Also in there, in your mucous membranes, you'll have the mast cells that contain histamines, which can lead to some of these problems. The common cold, or rhinovirus, is all it is, that affects the nasopharyngeal tract that goes all the way down. Acute rhinitis, which is the inflammation of the nasal mucous membranes. Sinusitis is the inflammation into the sinus itself, and acute pharyngitis isolates itself to the pharynx. When we get in a little further here, keep in mind when the reason I did this right behind the autonomic nervous system is because it's response to this. The sympathetic nervous system, or adrenergic, constricts the vessels, the mucous membranes, or constricts the vessels in the nose, leading to a decreased thickness in the mucosal wall and making that widen, making air movement easier. Whereas the parasympathetic or the cholinergics increase the blood flow to these mucous membranes in the upper respiratory tract, which is the opposite of the sympathetic or adrenergics. So this release by cholinergics affect the parasympathetic system. Arterioles dilate, that increases the blood flow, and that increases inflammation, increases mucus production. So just keep that in mind. I will mention that again as we go along. I'm sure everyone has heard of antihistamines. They are the H1 blockers or H1 agonist. They block, or I think I said agonist, H1 antagonist. So they block or they antagonize, go against the release of histamines from those mast cells. There's two generations, the first and second generation. First generation, good old diphenhydramine or Benadryl, that is very, very sedating. The newer ones are not as sedating. Some people are still very sensitive, but they're not as sedating. Some key things to remember: I mentioned H1 because there is H1 and there's H2. The H1 histamines being released, the way these blockers or antagonists, antihistamines work is they compete for that receptor site. They compete with the histamine for the receptor site, so try to block it off so that you don't have that histamine response. Histamine can be released, it's just trying to keep you from having the histamine response. That's where an antihistamine working against it is different than when we get into mast cell stabilizers a little later. H2 blockers, which we're not going to discuss in this chapter, just so you know. The H1 blockers are the histamines. H2 blockers are medications that work in your stomach at the receptor sites down there. Okay, so diphenhydramine, so it can be given in several different routes. There is a chart 40-1 on page 575 in your text. Definitely causes drowsiness. I'm sure everybody or most people have taken diphenhydramine at some point. And why do you think it causes this drowsiness? If you think back to your system, diphenhydramine, the first generation of antihistamines, had such an intense anticholinergic response. So your parasympathetic that has all this fluid release there, it's working against those, so taking up those receptor sites, so you can't have that. The second generation have less of this interaction. So sticking with diphenhydramine or Benadryl, contraindicated in severe liver disease, narrow angle glaucoma, and urinary retention. Think again, you can remember what it's against. If it works as an anticholinergic, then it's going to affect that parasympathetic side, and you can figure out the precautions. What are some nursing interventions that you want to do? They have in your text, they have the whole nursing process taking you through and things to consider, such as getting a list of their environmental exposures, drugs, recent foods eaten, stressors, trying to figure out what it is triggering this. They may have a known allergy, they may have a known hay fever, which is up in the upper airway. You should take it with food to decrease irritation, GI distress, avoid operating motor vehicle. If they're drowsy, definitely avoid alcohol and other central nervous system depressants with it. It may cause mouth dryness, and again, it's the old things of sucking on a piece of candy, maybe a lemon drop or something. Lemon is actually good food, stimulate that saliva. Diphenhydramine is found in almost all the over-the-counter sleep aids. When it's Tylenol PM, you'll look and they'll have 50 milligrams of diphenhydramine in it, and that's why you sleep so well. But I can't take it. I feel like I have a hangover when I wake up. So diphenhydramine, I don't know, yes, it does. I'm sorry, I was just looking in text to make sure that it went over some of the dosing with this. Obviously, your dose, IM or IV, are going to be different from your doses that you're going to give by mouth, because remember the first pass effect. And anytime you're giving anything to children, you're going to do it by their weight, by kilograms. You should have done all your calculations and have a good idea about how to calculate that out when you're given. If you're looking it up and it tells you so much per kilogram, you can calculate if it's a safe dose. See the adverse reactions on the chart there, which definitely causes some blood dyscrasias, problems with your blood formation. Sorry, let me go back. I'm not going to go into every single one of the antihistamines. There's a chart or table for 40-1 going over several other antihistamines. The diphenhydramine is the first generation one I want you to focus on. And let me see, go down here to second generation. Those are much more common now. Astelin is just the nasal spray. The oral ones, fexofenadine, which everybody knows is Allegra, cetrizine, which you probably know as Zyrtec, loratadine, which you know as Claritin. Those are the major ones, and kind of have a clue of what the dosing is there. Not memorizing it, just being familiar. Okay. Now go on again. We'll get to the nasal congestion. nasal and systemic decongestions, beginning on the bottom of page 574. And I explained in the beginning about the congestion from the blood vessels, and to decongest them, we have to give them sympathomimetic or those are ones that mimic the sympathetic system. So by stimulating the sympathetic response, do you remember which one? It was those alpha-1 receptors that vasoconstrict the blood vessels. So if they target the alpha-1 receptors or do the same, mimic those, and it can decrease this response that you're seeing here. There's several medicines that can be used. Sometimes they're taken orally, sometimes they're in a nasal spray. A big teaching with these is not to use them very long. Usually it's just for a matter of like 3 days or so, because you can have a rebound effect where it actually gets much worse than it was to start with. Now, getting it in the nasal form, it may not last as long as taking it by mouth and having it systemic, but it works much more rapidly with fewer side effects. They have made some nasal sprays that work longer than others. Table 40-2 gives you systemic and nasal decongestions, how they're used, what their dosing is, things to consider. Now, some of the ones that you should be familiar with, if you haven't been doing it, you want to start looking at some of these over-the-counter when you take medicines, because there's ephedrine, phenylephrine, and pseudoephedrine, which are systemic decongestants. And pseudoephedrine now has, well, some counties you have to get a prescription for it. It has been used widely in making meth, so it is very difficult to obtain. I know in Giles County you have to get a script for it. Some counties you have to consult with the pharmacist, and they only give you so much over whatever period of time. Here's a few that I pulled out from your chart, and the names of the actual nasal spray or oral tablet. Phenylephrine or neosynephrine is one that I often recommend to patients to use, but again, it's like a 3-day and off, or it can have a terrible, terrible rebound. Ephedrine, primatine is a funny looking pump. That's another common one. Trying to think of what else you should keep. And pseudoephedrine, which I mentioned. Side effects. Again, if you think about affecting the sympathetic nervous system, you can figure out some of the side effects. The nervousness, restlessness, jitters. Frequent use can lead to tolerance, that rebound, which I've already mentioned. Here's just a reminder from the old one on the sympathetic response. Intranasal glucocorticoids. Glucocorticoids are what you will hear referred to as steroids. There's multiple types of steroids, but the glucocorticoids are what you will often hear as steroids in the medical field, and they have an anti-inflammatory effect. That's why they're often used in nasal sprays to directly affect that inflammation. And here's several names of them. You can find these in tables 40-3. Usually it's 1 spray, occasionally 2 sprays for an adult. Just teaching on how to administer it. Covered that, I think, in the previous with having them blow their nose, do the spray toward the sinus cavity itself. In the child, you're going to go up, very young child, you're going to go up because they only have their ethmoid sinuses formed at that time. They do not act as rapidly as the previous that have the alpha effect that affects immediately. This takes a little longer, about a week, to really bring about the response, but it works longer and is a little safer without that rebound. Okay, so antitussives, as it says, act on the cough center and then do to suppress the cough reflex. Be very careful, never give over the counter to a child under age 2, and any child up to age, I think it's like 12, they should have a medical provider supervision and recommendation of whether to take it. Antitussives are just for temporary relief. Some of the side effects are nausea, dizziness, drowsiness, fatigue, and sedation. The 3 different types, it may or may not have a narcotic in it. Dextromethorphan should be very familiar with. It's in almost all the over-the-counter cough remedies that you can find. Opioid codeine. Codeine is a great cough suppressor. So codeine, dextromethorphan, sorry, having trouble with that word today, and hydrocodone. Hydrocodone and obviously codeine and hydrocodone are controlled substances that can be combined with other medicines such as dextromorphan, sometimes not diphenhydramine, Phenergan, which is promethazine, another antihistamine type of drug. So sometimes those are given together and they work to slow down that cough reflex, lowering the cough threshold. That's why those dextromethorphan or cold medicines can be dangerous on a young child or an infant because of lowering that cough threshold, and they have enough difficulty maintaining or controlling their airway, so you don't give it to them because you're increasing the chance of a problem or developing pneumonia or an aspiration. The other one listed here, benzoninate. I don't know if you've ever heard of Tessalon pearls, benzoninate. They are great. It stops that tickle in the throat. It works by anesthetizing the stretch receptors in the bronchoalveoli and the pleura, and it's great for that cough, that dry, non-productive cough, for all these antitussives. Expectorants. Expectorants help to loosen up those bronchial secretions so they can be eliminated. That's for that thick cough and you can't get it up. Her side effects can be drowsiness and nausea. Nursing actions, encouraging fluids. There should be 8 ounces of fluid at least 8 times a day, and never to take longer than a week. Some people will get multiple meds with guafenicin in it over the counter. 3, 4, 5 days, it's worsening, it's not getting better, they're running a high fever, they need to be seen and stop taking it. Guafenicin is the one I listed here because it is the most common one that is in so many of the over-the-counter medications. Dextromorphan, there's a prototype drug chart 42. You definitely want to look over the patient-centered collaborative care on the common cold. On the next page, 580, antitussives and expectorants are in table 40-4. And just looking at some of those combinations, the ones I mentioned, if you look under non-opioid antitussives, you will see promethazine with dextromethorphan. That is the Phenergan I was talking about with a combination, or sometimes it'll be in a combination with a codeine or a hydrocodone to help suppress that cough. I didn't put any slides for the end here, the sinusitis and acute pharyngitis. Just read what that is. The medications we've discussed are usually used to treat these, along with maybe some analgesics like acetaminophen ibuprofen, over-the-counter Tylenol, and Motrin. Okay, so that's the end of this, and then move on to chapter 41 for lower respiratory.